right, thank you so much. And welcome again to the CE content for the impact of pharmacy teams implementing health equity services. I don't have any relevant financial disclosures. And then objectives are listed here both for pharmacists and pharmacy technicians. And we'll hopefully hit details on each one in the coming slides. So very first deep dive before we go into some of how to maybe implement or think about this in the pharmacy workflow are what are social determinants of health, or SDOH. I've also heard social drivers of health as well, so same concept as far as terminology. And when you hear me talk about social determinants of health, hopefully this will spark some, wait, that's something we can impact in pharmacy, because we thought the same thing here in Missouri. So social determinants of health are the conditions in which people are born, grow, work, live, and age. And so if you're also thinking about your community pharmacies and pharmacists all over the healthcare settings, this is absolutely where you start. You're born, grow, then you work in the pharmacy and live throughout that community that you're serving. So again, the correlation with pharmacies starting with slide 1. So deeper dive into those social determinants of health. And giving some really brief examples here. Actually, this came up in really understanding social determinants of health at recently, for me at least, at a business health coalition on a national stage. Even the businesses and then the employers were seeing social determinants of health as patient demographic information, and versus all of the multifaceted components of where they live, how they live, and who they live with, and that could be impacting their health. So thinking about economic stability, this one's pretty easy to compare why this would impact your health when we're living in the US with employment, income, expenses, and debt. Then also thinking about your neighborhood and physical environment. So when I go back to that business health meeting, it really correlates with a benefit, for example, that one business had as a walking app. So I'm going to have, encourage my employees to walk 10,000 steps a day. We have this fun mobile app, but by the way, the places that my employees work or live are not safe to go walking all of the time, or there isn't safe sidewalks to walk on where they live. So that was something that paying for this benefit by this employer or health plan was not really a great option. And then education as well. In healthcare, obviously, we immediately think of health literacy, that this isn't just impacted by your education. But also food, access to food, food insecurity, community and social context. So what support structure and social systems you have in place, and then the healthcare system in general. So the quality of care, the quality of, or the access to quality care, et cetera. And these all tie in ultimately to those health outcomes: mortality, morbidity, health status, and really evident here in the impact of those health inequities. So for example, in Philadelphia, you have zip codes that are 5 miles apart, so you can walk from one to the other, that have up to a 20-year difference in life expectancy. In Miami, the average life expectancy for babies can vary as much as 15 years, also within that 5-mile distance. And then in Richmond, the average life expectancy for babies born within 5 miles of downtown can face up to a 20-year difference from babies who were born just a few miles apart. So really, this shows why those social determinants of health are impacting our health outcomes. And the bigger picture here, like why healthcare needs to understand this, and those in healthcare or public health. And it's because 80% of a patient's health and well-being is going to be related to those physical environment and driven by those social and behavior factors. So if we're only focusing on healthcare, access and quality care, then we're missing 80% of the other things that are impacting a patient's overall health and well-being. And There's also been much more specific community health data than before. So looking at what your community looks like is really a great place to start. What does your community look like? How does it rank compared to the rest of the state? And then what are the major burdens of health in your community? And when I talk more about things that we've done in Missouri, this is really where it started. It was a community coming together and saying, how do we compare? What are the major burdens and what are priorities that we want to focus on to have an impact on? And ultimately, who cares, or why is this a big deal? Considering that health inequities can account for $320 billion in annual healthcare spend and could grow up to $1 trillion by 2040, anyone who is paying for healthcare cares. So that can trickle, from the top to the bottom. All of us should care about why this is a big deal. Also considering that the US spends much more on healthcare, and yet we don't have the healthiest people in the world. So if we're going to spend this much money, do we want to make sure that it's going to the right things that are impacting health and well-being overall? And then bottom line, there is a health equity index that CMS announced that will incorporate the risk adjustments made for contracts and payments. So it could create around a 40% payment model based on a plan's ability to address these health inequities. And I want to share this because ultimately there's a lot, when we talk about social determinants of health, there's a lot of question of who's responsible. Ultimately, this is going to be the healthcare plan is going to be responsible for now because they're the ones ultimately paying for that bill at the bottom line. However, everyone needs to be aware and be able to understand and then address social determinants of health, or this won't get better. And then why us? So I maybe alluded to this in my first slide, but because our practices are located in the middle of where people are born, grow, work, live, and age. And actually this photo is of a patient in Charleston, Missouri, in the boot heel of our state. It's one of the poorest areas of our state and has some of the lowest health outcomes of the nation. But we as pharmacists and pharmacy teams are actively supporting and addressing social determinants of health to have better health outcomes than other places. So this picture is of a patient receiving a vaccine. And so I just love sharing this one. And I want to highlight too, this is a patient who her only mode of transportation is her motorized wheelchair. So a couple of years ago, actually, she was asked to use to use a chain pharmacy that was 40 miles away, which it doesn't matter how you look at it. This wheelchair is not going to get her to that chain pharmacy in 40 miles. So she can roll down the street to the pharmacy nearby, or they deliver to her. And so just immediately thinking of that access to care, but the 80% of other factors in her life and environment that are impacting her health, her community folks and community pharmacy folks can help support and overcome those barriers. And why pharmacy? So I know primarily I'm preaching to the choir here for any of my pharmacy folks on the line, but we see patients much more often. So your chronic patient, patients with chronic illnesses will see their primary care provider on average 3 to 4 times a year, and they're going to see their pharmacy 10 times more often. So on average, 35 times a year. And I also want to highlight that when they come in, also, there's different aspects to those touch points. So some may be coming in for over-the-counter items, an opportunity to have a discussion about something else. Some may be coming in to pick up for family members or themselves. And then even thinking about myself, I have a high maintenance dog. I'm going in to pick up a prescription for her every month as well. So the number of times that a pharmacy team can interact with a patient and be able to answer questions or dig a little deeper, because patients obviously don't always know what questions to ask. and find out more information. But then also on the reciprocal end, having a very distinct and strong relationship with those patients because we see them so often. So they may be more comfortable with their pharmacist or pharmacy team member in speaking, especially in thinking about some of the social determinants of health questions. And how do you find out that someone is food insecure? They're not necessarily just going to open up about that in your first or second meeting, or even if you see them every 4 to 6 months. So in pharmacy, when we're thinking about the lines of business and adding a new service, the health equity line of business or health equity services in a pharmacy are definitely going to be different. They're not associated with a prescription sale. Contracting for them is different. Even the opportunity for partnerships is going to be different. And pharmacy, again, preaching to the choir, but we're really in our own little silo, in our own little bubble. And all of the other members of the healthcare team are operating in a different bubble over here. And so this idea of health equity services, actually, I'm going to hopefully share how they integrate and build a bridge across those two silos or bubbles. And our challenge here, so how I mentioned before that, ultimately who's responsible for overcoming social determinants of health and addressing the barriers related to care. And if we're looking at this as a service that community pharmacies offer, can we bill for food if someone's food insecure? Can we bill for firewood if they don't have heat in their home? Can we bill for playing bingo to keep them engaged and from loneliness? Can we bill for transportation or housing services? I watched a TED Talk that said this the number one priority prescription that a homeless patient needs to be healthy is a house. So can we bill for housing services? And can we bill for health equity? Also, I will say too, from the business side, this is always the first question that community pharmacy owners would ask. How do I bill for this? So I'm going to share a little bit about that as well. In thinking about health equity services, we really, while they integrate with some of the services that we already offer in the community pharmacy, they're probably going to be their own line of business. So you have your prescription sales, over-the-counter sales, which may include fun items and not just over-the-counter medications, clinical service sales, so COVID testing, DSME, other like durable medical equipment, and then adding a line for health equity sales for those health equity services. These actually may already exist in your pharmacy before you even leave this webinar. One of which could be free delivery. So a health equity service that is providing access to patients who cannot leave their home or don't have great access to transportation would be those delivery services, for example. And other things that you may offer at your pharmacy because patients see you 35 times a year, thinking about how those integrate in and provide increased access and equal access to care. I'm also going to give a patient case example here. So you've got two patients that are a married couple, and the pharmacy identified slow payments on their charge account. So it was taking more than 90 days to make any payments on their charge account. This past winter, though, their HVAC system broke and they couldn't afford the outrageous bill that went along with that. Their roof needed to be replaced. Both of their walkers are broken. They needed help with lawn care at their house. So they were really struggling to make it out of their house because of the buildup of the need for lawn care. And then they need their bathroom remodeled to include a walk-in shower to allow for safer bathing. How many of these issues are the responsibility of the pharmacy? But also, how many of these issues would the pharmacy potentially know about without having to do much digging or questions for these patients that they wouldn't open up about all of these issues in a single meeting? So ultimately, who is responsible? So I also want to touch on the fee-for-service model. This doesn't always integrate with social determinants of health services. So there is an example. We have actually have states that have health risk assessment surveys that they pay, fee for service each time you submit information after a health risk assessment survey. You get paid a fee for doing this with a patient. After administering the screening, you bill the payer. They pay you for the screening. But really, in the social determinants of health results, they're screened. Then what? No interventions made to identify to work on addressing the risks involved. So you screen a patient and you find out that they're food insecure, you bill the payer and they pay you for it, and moving on. That's not really a great patient care example overall. We do want to solve the problem, right? We want to address the issue so that that doesn't continue to happen and that we can support that patient better in their healthcare journey. So service payment is not dependent on this social determinants of health problem being resolved or the patient improving in any way when it's fee for service. So probably not the best model for social determinants of health or health equity services. But it is being done across multiple states. So I know I may have sort of answered this a little bit, but I'm going to ask the audience, who is responsible for addressing social determinants of health? Is it employers, the medical insurance, all of the healthcare providers, including pharmacy, or the community in general? And I'm only going to give a little bit of time if you want to pop in the chat A, B, C, or D before I jump in with my quick answer on this is sort of a trick question. So I know I would say B is the primary answer because it is ultimately the medical insurance who pays for it at the bottom line. They're on the hook for what happens if those solutions are not met and those needs aren't met. But ultimately, it is everyone, right? Employers who pay for the medical insurance may also want to be responsible so that that doesn't happen. But is it the employer's job to make sure that the patient has food? Yes and no. And is it the community's job? Yes and no. Is it other healthcare providers? Yes and no, right? So it's really kind of everybody. And ultimately, the bottom line, though, if we're looking at the biggest impact in the long run for payment is going to be the medical insurance. So moving into value and outcomes-based arrangements, because this is really where social determinants of health screenings and health equity services lie. This example would be administering that health risk assessment or a screening, and afterwards, a CHW or community health worker utilizing that survey to develop an action plan. So finding out where problems lie, referring to local community resources, depending on where and what those are, making sure that the patient received those resources or got connected with somebody at those organizations, had care delivered in whatever manner they needed, and kind of almost like a loop, like follow-up care, and then other personal approaches or personalized approaches. The example here is that ultimately the service would be, or the payment would be dependent on the resolution and the patient improving and their health outcomes improving. And this is probably the hardest nut to crack for other healthcare settings or providers, is ultimately having that closed loop. So providing the assessment and then making sure at the end that we followed up, we refer, we follow up, we make sure that that loop was closed and that patient's care was provided. And maybe that care is not health care though, so keeping that in mind. But ultimately, this is where pharmacy can play a huge role and can have a huge impact. So CHW engagement in the pharmacy. So we're going to talk about community health workers specifically in pharmacy. And hopefully in some of the past examples, you've already started to think about how a CHW would make sense in a pharmacy or how the two mesh and serve well together. So thinking about community health worker engagement is in the conversations that pharmacy teams are already having with patients. So you're asking about how something about medications, and then, oh, by the way, how do you like to get your medication information? Or tell me about that situation in a little bit more detail. These are questions that are harder to ask if you don't already have that rapport and relationship built. So again, makes it pretty easy for the pharmacy team to integrate finding the answers to these. Maybe it's not a flat out, what are your worries, but that you can find this out by having these conversations over the course of 35 times you see them in a year. And then utilizing the screening tools and creating some peer-to-peer relationships. This one is really key to the CHW pharmacy technician role, those peer-to-peer relationships, because we're now really connecting CHWs in other spaces with those in the pharmacy, and then reconnecting with the healthcare space as well. So thinking even about receiving referrals and connecting patients the way you would in healthcare to all of the other resources that are in your community. So I can refer somebody to have help in getting transportation, or I can refer somebody to this organization that helps pay for XYZ, maybe your heating bill or your AC bill. And I can refer patients to this facility to help them find employment. So when I'm talking about referrals here in the context of social and community organization referrals versus healthcare referrals. And then what does the CHW look like? So it's all about local care. So the CHW, just like a local pharmacy, is integrated in their community so they understand the local services and resources available. So in thinking about how you would refer a patient to a community organization or resource, you need to understand what that organization would offer in your community. And community health workers, typically the gold star or gold standard of their course, has been creating a community resource binder. So it is a binder of all of the resources available that are specific to their community. And then having contacts, because throughout the course, they would have contacted and made relationships with contacts at those organizations. So going back actually to the last note on this slide, creating those peer-to-peer relationships. So having a contact at those organizations to call and ask questions or follow up so that things get facilitated and taken care of in a timely and efficient manner. And ultimately, a pharmacy community health worker looks pretty similar and is probably not very different in things that they're already doing today. So they're helping with prescription access, they're helping with pharmacy services and getting support. Care coordination has been a huge one because it also makes sense when you integrate with delivery drivers and have that peer-to-peer relationship with other organizations in healthcare as well. And then care coordination actually is a big one that isn't done well from a call center. So it's done really well from a community member or community team, like a pharmacy team. And then local projects and contracts, community involvement. So there are very specific projects or grant programs, for example, focused on specific needs of your local community. And that is where pharmacy CHWs can make a huge impact and be involved through those peer-to-peer relationships. And then one that I'm also going to touch on more is that pharmacy differentiator to the healthcare community. I think this is where, when we're putting pharmacy in a box to say we're only here to provide prescription access, prior authorization support, and just anything just tied specifically to dispensing services. While dispensing services are the floor, they're not the ceiling of what the pharmacy can provide for their community. So a CHW opens up that limiter in others' minds. So they see the pharmacy differently in what they're providing for their community. So just some examples of pharmacy technicians working as community health workers. So there's the service coordination. So thinking about helping patients navigate the healthcare system or social services. This has been a huge one because, as you know, the healthcare system is a maze. And even for pharmacy staff, we don't like calling your health insurance any more than you do. And so that's where helping patients navigate those conversations, or when they they kind of hit a wall, you can help overcome that. In this informal counseling, care management, they're a community advocate as well. So in these landscape assessments for what a community's needs are, those CHWs play a very important role. And basically, I like to think of CHWs as your healthcare accountability buddy. They're there to help, or your community healthcare accountability buddy. They're there in between all of the other visits and needs in the healthcare space to make sure you get what you needed, that you take care of what you needed, or the recommendations that fall through the cracks, like vaccines, for example, get brought back to the top as a priority, and that other things of life don't get in the way. CHWs also are phenomenal public healthcare workers. So list doesn't change, right? It's very similar to what was on the previous slide. And it opens the door for the pharmacies to be involved in public health. Now, honestly, this slide before the pandemic was why pharmacy and why pharmacies should be involved in public health. After the pandemic, it's more, where can pharmacy play a role? And CHWs open that door even wider to say, when, where and when, because we can start yesterday. Also sharing on the care coordination side. So this component is huge with community health workers and health equity services. So with care coordination, I mean, even thinking about something as simple as a recommendation for lab work. So my doctor wants me to get lab work done. I need to get some blood drawn. I leave and I go home and I completely forget about it. I see my doctor again in 6 or 12 months, and that's when they ask me about that blood draw, right? This is where your CHW pharmacy team could play a role. If we are able to help coordinate in between those visits in the 35 times that we see that patient or more, in between those primary care visits, right? Or in between a primary visit and a specialist over here and somebody over here, we're already that healthcare hub. So why not add another layer of care and being a resource and hub for our communities? There are also social determinants of health risk assessments. So the tools here, like the Prepare tool, honestly, these are wonderful, but they don't always work well in pharmacies. And I'm going to explain a little bit more in depth on that, depending on, I guess, where the pharmacy is. So I want to share that these exist because typically these are brought up as here's things that pharmacy teams can incorporate, especially if you go back to that fee-for-service slide. And these are things that we don't always need to incorporate the same way in a pharmacy. So thinking, we're in our own little silo over here, but let's think outside the box compared to another silo, because ours will be different and how we can have an impact. And then sharing, sorry, I meant to click on that. Sharing, like, for example, if I'm a pharmacy team member connecting with a patient and I'm asking them these lines of questions, right, in a survey. Are you worried or concerned that in the next 2 months you may not have stable housing that you own, rent, or stay in as part of a household? I'm probably going to get a funny look from a patient who's coming in for their monthly medications. So I'll share how we changed that verbiage or approach with a program that we had in Missouri, and then how that program is not just a Missouri program. That is an idea that goes elsewhere. So here's just other examples even of how this has been done in pharmacies. These questions are probably a little bit more in line with something you could ask on a call with a pharmacy team, but still a little bit survey-y, right? And it's harder to implement a survey like this within a community pharmacy. But thinking about those health equity services, there are what do these look like in a pharmacy? So they could look like that screening tool, for example. They could be similar to those screening questions. So you conduct the screening, you fill out the questions and get that documentation, and then you have the resulting data. This is actually where I want to touch on a little bit more, because how we do that screening and then document is also going to be a little bit different in pharmacy, since we're not always utilizing an EHR. But the resulting data, the Z codes, which are ICD-10 codes, related to social determinants of health, and then that demographic information. So the data that comes from incorporating social determinants of health into pharmacy interventions is phenomenal. Actually, our health association in Missouri, our hospital association, is very interested in tracking health equity data and Z codes specifically, but they're only able to look at the hospital discharge data. So if we could pull that in with community data as well, that would make a much stronger health equity dashboard, and then being able to address those barriers as a team. There's examples on this slide of current opportunities that pharmacies have been involved in. So those specifically focus on health equity and with community health workers. I'll add that these have exponentially grown since even the creation of this slide. So COVID vaccine hesitancy, vaccine gap closure education, SMBP education or medication optimization. We have programs with maternal health, migraine prevention, cancer screening, chronic care management, care coordination, outreach marketing, and then data acquisition and reporting. And actually the numbers on this slide are also probably much smaller now than they are now. And I'll share a very specific example of a program we had that is really used as a model here. Oh, and I forgot, I added this here. So additional opportunities. The biggest thing being the data that is provided through that documentation of interventions with pharmacy teams. It's just an area being, embedded within your community that isn't accessed as easily or as longitudinally as it is in pharmacy. So with the example I included earlier with the data is just starting with the Z codes, those ICD-10 codes that are documenting social determinants of health data. And I have examples here of what those Z codes look like. And also keeping in mind that how you collect Z code information and data can't be a one-time, one question, checked the box, yes, we're good to go, right? So if I have problems related to a social environment, Z60, that could change tomorrow, right? Or it could occur tomorrow compared to others, right? So maybe I'm going to have diabetes now and for the rest of my life, but Z60 could ebb and flow, right? How we even look at social determinants of health coding gets a little bit more complicated, but makes sense in a community pharmacy that's going to see that patient much more often, more than monthly, right? Oops, sorry, trying to push the button. There we go. So an example here, each Z code 2 is broken down just like other ICD-10 codes, but just sharing that those get very specific in the social determinants of health data that they're collecting. So you may have problems related to education and literacy, but we're going to zoom in on Z55.3, and it is underachievement in school. Going back to those more standardized surveys, it makes it harder to get to this question if you're asking this standardized survey in a one-time, discharge or intake form, right? So bringing it back to, if you're going to see patients 35 times a year, this is where this information is shared in one of those visits. All right, so an ask the audience moment, and I realized now that I probably can't see the chat, but I'm going to give you some time to think through this while I go into a deeper dive on our one of the specific programs that we incorporated this into. So ultimately, how are you defining the value of pharmacy services? So I love hearing what the 10-second pitch to non-pharmacy partners sound like, especially if they're also not in healthcare, because we all come with our own, subconscious or our biases about pharmacy or what pharmacy could do if we're not in pharmacy or healthcare. So what does that pitch look like if you were to say, I want to get paid for pharmacy services? What does that look like or sound like? And if it's only in 10 seconds, right? All right, so as you're thinking about that, I'm going to come back to that question at the end and share how mine has changed, which it changed very drastically from a year ago to today because of this program. So we started the Missouri Pharmacy Vaccine Gap Closure Program with grant funding from our Department of Health and Bureau of Immunizations. This started in January of 2024. So we integrated it into a phased approach. Basically, the overall goal was we think and know that pharmacies can have a huge impact on community vaccination rates, and we want to make sure that we can show that. So we asked pharmacies to document very extensive information into their this documentation form, and then this was in a 5 to 15-minute encounter. So we asked for health conditions, health-related social needs, detailed demographic information. And in this program as well, we trained our pharmacy technicians as community health workers to start. So each pharmacy involved in this program had to train at least one pharmacy technician as a community health worker. So to date, we have over 400 or 200, sorry, we've trained over 1,400 across the nation, but we have over 200 in Missouri at our pharmacies here. So we had 135 pharmacies or so participate in this program, and each had at least one, if not two, community health worker technicians. And I wanted to share why we incorporated technicians, that this was tying the clinical aspect of care with the social and community aspect. So I had a tech CHW say it best, that my pharmacist talks to them like a patient, and then I come in and follow up and talk to them like a person. So it's bridging the health care with the community. Also in the pharmacy, I mean, we all know that we have extremely broad access to patients. So it's not just those 35 times a year. There's also no appointment necessary to see the pharmacist or CHW. We have at least those monthly touch points, and then the opportunity for home visits as well with delivery drivers. So we have pharmacy techs that go out with their delivery drivers and do home visits as well. So our pharmacy gap closure program was built on a longitudinal care process that basically is MedSync with a fancier title. So we're using the MedSync program to build a longitudinal care process. Ultimately, the MedSync program pharmacies have already these processes in place with their workflow as well as their software and vendors. So you're not having to buy and learn and document in some separate software. You are using your current software and your current workflow. And then also the MedSync process typically includes the pharmacy team. So it is not just one person or one pharmacist in overseeing this program. It is the whole team's aware and involved. And this is the value that I saw in the pharmacy to the healthcare system in general. So it's this consistent and longitudinal process for follow-up and monitoring. This doesn't happen elsewhere in the healthcare space. The patients are answering the phone, that I know that they're going to come in, every third Thursday of the month to pick up, and that I'll have a chance to connect with them in between on a phone call as well. So while the MedSync process starts out, initially as this is more convenient for patients to pick up all of their monthly meds on a single date each month, you also have very routine touch points now that I can layer in 5 to 15 minutes of education or follow-up or monitoring that doesn't exist elsewhere. So in our pharmacy vaccine gap closure program, we incorporated this 5 to 15-minute vaccine hesitancy education into the MedSync workflow and calls. So each patient would be screened by the pharmacist for what vaccines they were eligible for prior to that call. So those patients would receive a monthly call anyway, so they're already going to answer the phone to talk about what meds they needed that month. Now we're adding on the pharmacist did an eligibility check. It looks like you're due for your shingle shot. Are you interested in getting that today? So we're incorporating that, but also detailed, again, demographic information so that we can make sure everything is up to date, allergies, address, race, ethnicity. Because we utilized community health workers, we also did a health risk assessment with each call. And then these calls were not a one time we call and we're done. These were longitudinal calls that occurred every month. And we did not find out the outcome of that or whether a patient received a vaccine until the following month. So why it works, we know that the workflow model already existed. So we're building on a model that's already efficient and works in the pharmacy and uses current pharmacy software. We have that established relationship and rapport with patients. They answer the phone already. We're not cold calling and talking about vaccines. We are calling them every month already about their medications. And oh, by the way, did you want that flu shot this month, or did you have follow-up questions? Or I had CHWs who said there were patients I knew that were going to say no. They said it every month. So rather than bug them about that, I said, and if you have any questions, I just want to remind you that I'm here to talk. If you have questions about vaccines, because I care about you, but they're still going to answer the phone next month because we're calling about their medications. We did expand this to the community as well. So we had community care clinics that included education or information. And this was just anything that provided vaccine information or access to vaccine administration outside of the pharmacy walls or business hours, listing examples here. And then the last phase was our CHWs providing care coordination. So this was if a patient at a clinic had a second dose due, or they only received education, and now I'm going to follow up to see if they did want to get that shingle shot, that I'm going to call and figure out where is most convenient for them to get it. Because if I'm doing a community clinic at a city hall or a YMCA, those patients may not use my pharmacy. So they're not having to come and use my pharmacy to close that gap. Our CHW techs would call and coordinate and schedule appointments anywhere that was convenient for them as many times as it took until they could verify with the provider. So the nurse at the health department said, yes, they got that vaccine yesterday, you're good to go. They would help coordinate all of that until then. Really actually until there was a no also. So if a patient, they called to coordinate and they said, never mind, I changed my mind. I didn't show up because I don't want to go, then that's where that stopped, because they may not have that same rapport of that MedSync monthly call with patients in the community. But my wow factor slide is this one. So we had 80,000 vaccine hesitancy and education interventions completed. Our gap closure rate was, I say approximately 22%. This was probably more of the minimum because we stopped this program on October 7th of 2024. So, in peak flu and COVID vaccine time, we were not able to do follow-up calls to find out if those vaccines were received. So some of this 22% is probably a low ball number. In other programs where we've copy and pasted similar models, it's more around 60% gap closure rate, where they collected that information without needing a follow-up call. We were able to reach over 91% of zip codes in our state. And then we have, like I mentioned, that detailed information on each patient. So we know there were 5,300 with self-identified disabilities, over 24,000 with comorbid health conditions, and 6,100 with health-related social needs identified. Total, we had over 100,000 interventions when you add the care coordination intervention as well. And we had over 500 providers, which included pharmacists and CHW techs enrolled. In those community care clinics, they actually didn't open until the end of July. I think it was July 22nd. We had over 12,000 vaccine gaps closed in those community care clinics in the 2 months that they were open. We also asked for health equity focused vaccine clinics. Could we keep funding anything in order in October? We had 132 requests that would have closed gaps for 6,300 uninsured patients, because these were specific for uninsured patients. We ended up not having any funding to fund to continue, but I loved seeing the diversity of the reach of where those clinics were going. And so now when we share that data, basically the question is less about, what can you do, and it's more when can you start? So the CDC is interested, insurance companies, life sciences companies, even partnerships with other organizations and healthcare systems, foundations, et cetera. So just kind of an example of CHWs in practice, this was some of the information we share with our pharmacies in that vaccine gap closure program. We had a leaderboard report. So the pharmacies who would submit the top number of interventions, we would tag them to share best practices with everybody else, and really communicate across all of those spaces. And then, so basically too, thinking about our cross-trained technician CHW. So I kind of share that program as an example of ways that we can cross-train the technician CHW and incorporate them, because really the vaccine gap closure program, you can insert anything else for the word vaccine. It can be primary or preventive care gaps that can be closed because of the partnership of the pharmacist and technician CHW. So even in, and I think initially too, sorry, before I forget, for any pharmacy that would be new to implementing a health equity service, I think the biggest thing is you have to give time to incorporate these services into your pharmacy. So if you do cross-train your technician as a CHW, give a set amount of time, even if it's 2 hours a week, that is spent devoted to this role and integrating it back in with the role that already exists within the pharmacy. So my ask the audience, thinking about how you are defining the value of pharmacy services. You are welcome to share it in the chat. I'm not always able to see the chat though when I share my 2 screens that hides everything on Zoom from me. So and I think I want to leave some time for questions. So I'm also going to share what mine was. So this looked very different than it did even 1 or 2 years ago. 5 or 10 years ago, I probably would have said that the pharmacist is the medication expert. But when I think about the value of that to patients in the healthcare space and the healthcare system in general, probably not something that people would pay directly for, right? They're not going to pay for the medication expertise. They may even think that that already exists in other healthcare providers, which it does to an extent, right? So my definition of the value of pharmacy services has changed to say that our pharmacies interact and engage with patients longitudinally and multiple times a month. Our patients answer the phone when we call. So we have a patient engagement and reach that no one else does. Not only do patients have access to the pharmacist has access to patients. Our pharmacies have cross-trained pharmacy technicians as community health workers. This one I want to just highlight has been our gold star or standard too, because it opens doors that no others have. It brings us to the front of the line or to sit at the table where pharmacy hasn't always been invited to sit before. And then that our community health worker technicians are always 6 feet away from a clinician, the pharmacist. So tying that social and clinical care together. And then all pharmacies are not the same. So pharmacies that are different. This is why. And then lastly, imagine the care gaps that we can fill. Oh, wait, you don't need to imagine it. We have the data to prove it. So it's not when can we, or, it's not what can we do? It's when can we get started? And I think I left hopefully the perfect amount of time for questions. So I'm going to share my email here and open it up for questions. Ooh, perfect timing.
Wow, thank you so much. That was really, really good information. I do have a couple questions here that we'll go ahead and go through. What does the sustainability look like for these pharmacies?
Yes. So that's kind of a twofold question to me. I think the sustainability of a CHW in a pharmacy is actually a more sustainable role than anywhere else that you might find a community health worker. So that's actually something that our Department of Health was probably more skeptical of our pharmacy techs becoming CHWs and has 180'd. They've said, never mind, this might be the most sustainable path because we already have a technician hat that has a full-time role that doesn't need to be funded by anything else. And we're adding the community health worker role to integrate in with that position. So we're not having to find grant funding to create a new position. We're not having to build to start from the ground up for a new position. We are adding this benefit in with our current teams already. So that was one kind of eye-opening experience too with our Department of Health and Pharmacy. But from the pharmacy's perspective, I know North Dakota is a little bit unique in that you don't have as much of a, competitive problem with chain pharmacies, but I don't think you're unique in any of the issues related to pharmacy benefit managers or dispensing contracts not paying the bills and keeping the doors open. So I think that pharmacy technicians as community health workers is the door opener or the first step to practice transformation and transforming the entire profession. For everyone, not just technicians and not just pharmacists. It's changing the entire profession because it changes the way that partners and payers view the opportunities and services that could be provided in a pharmacy. We've had conversations with payers that are not just related to dispensing. They actually don't mention dispensing in an hours long conversation before a contract. So that I think is also the other. And then I would add that at least from our experience, CHW technicians is not a onesie twosie. One pharmacy gets a CHW technician and they're able to do all of these opportunities and services. It is a statewide or network-wide opportunity that pharmacies in the state or the network say, yes, this is something we all want to do and impact. And that's our differentiator. That's what you contract with us for. That's what you pay us to incorporate into our communities and provide for our communities. So that's what we've been able to do in Missouri. And I guess that's the sustainable path. And it does take movement from more than one at a time.
Okay, and I have two more questions here to ask, but also feel free to put your questions in the chat now that we're at the end of the presentation, or you can go ahead and also come off mute. So I'm going to ask these two, but go ahead and ask your questions as well. Two questions here, I'll just ask in a row. Do pharmacies use a software to place referrals? And what has been the biggest barrier to implement?
So there are referral software available. That's actually something we've talked about with our Department of Health and then other healthcare organizations. So there's a couple off the top of my head. Some you have to pay to be involved in and others are free. The problem is that either they are only specific to social determinants of health resources, so those social resources and not clinical. So then it's kind of gets clunky because now you're separating the two when you've really integrated them in a pharmacy. And then the other is that I actually think that sometimes they play the role of the CHW technician in a pharmacy. So they're playing the coordination and navigation role that really is more impactful by that CHW in the pharmacy because they will try to close that loop by connecting everybody together. And they'll ultimately use a call center to do that. And that's where patients drop, right? We can't reach them. We don't have updated phone numbers, but the pharmacies always seem to have the updated phone numbers. They have the reach of the patient. So we have thought about using them and we've used them in like a regional pilot basis, but we have yet to expand on them because we actually really see the need to pay for the pharmacy CHW coordination versus a platform that doing that for you. And then I guess the other is there is the barrier of documentation and exporting the data from the pharmacy because pharmacy claims data obviously is not pulling that data the same way that like an EHR would. There are various pathways you can go depending on what data you're wanting to pull. So for us, like in our vaccine gap closure program, we just used HIPAA compliant jot form and had help on the back end with the PHI storage and then aggregating that so that when we received it, there was no PHI, it was just all totals aggregated. But and then being shared with our pharmacy school faculty, researchers, and brilliant minds to actually, analyze the 100,000 rows of data.
Sure. Another question that's kind of similar is what patient management systems are being used to link the patient information gathered in the pharmacy with their interaction with other social services they might be using? So, or how do they refer them out to other social services? Is that a phone call? Is there systems in place? How does that work?
Yeah, so it's probably similar to healthcare referrals right now, even maybe a little bit more disjointed. That's why the need is on the local level, because every local organization is going to have a different process. So we have some like in the Boot Heel in Southeast Missouri that are fax only, right? Or but that's where that CHW's resource binder would have the contact to follow up. And that's also why this makes sense in a community pharmacy, because you're going to see that patient again next month. And so you're going to pull that, or, maybe even sooner. So you're going to be able to follow up if they did not receive care, or did not receive the resource that they were needing. And you can help kind of navigate that. So yes and no. There's no one-stop shop for a management system or referral system, other than I would encourage, like, pharmacy ends up having to, log into 25 different systems. We're trying to avoid that by saying keep it in-house, right? Like, it's not necessarily needing to be an automated referral to this one if this one's not going to receive that anyway because it's fax or phone call or paper form, right? So if there's a way to have that CHW binder and then integrating it into just your pharmacy system. That's what we're trying to do, because I know pharmacy ends up getting, 50 logins that all are also going to need a new password in 60 days on a different timeline.
Okay. Well, one more question here, but will you flip it to the next slide for the CE code?
Yes.
And then I will ask the last question that's currently in the chat. So everybody, if you want to take a look, maybe take a picture, a screenshot of this code. It is, I put the link in the chat as well, learn.ceimpact.com. So the last question is, are you familiar or aware of what funding your Department of Health is using to support this work?
So we don't have funding anymore with our Department of Health. That was COVID funding that is now gone. We spent all of ours, but other organizations lost theirs. All of our partnerships now are with either, we have opportunities with our Medicaid program, with other foundations. We have some state foundations. There's some partnerships as well on the national level. So like there's like the grant pathway, but then there's actually just a contracting pathway with like Medicaid MCOs, or we're also looking at an employer plan pathway as well. That's a little bit trickier. So we haven't cracked that code yet, but looking to do that soon, because employers are also interested in addressing social determinants of health for their employees, knowing that it's impacting their health outcomes overall. So that one is another pathway. And then grant wise, like our grants are no longer with our Department of Health. They're again with either other types of foundations. So we have a Missouri Foundation for Health. But even large grantors are interested. So Robert Wood Johnson Foundation, MacArthur Foundation, the Department of Defense has like research grants as well. And then but I think honestly, the grants are no longer funding the interventions in our requests. They're funding that data infrastructure and data aggregation and paying somebody to review 100,000 rows of data. Because if you think that was only vaccine intervention, so if we expanded to diabetes and hypertension and asthma and anything else that, or just in general care coordination, I anticipate it's going to be significantly more than 100,000 rows. So we're going to need more data analysts and maybe a more efficient path for that. So that's what ours are funding now. We're billing the interventions elsewhere, whether it's to our Medicaid program or MCOs or Medicare Advantage plans.
Wonderful, thank you. Well, I don't see any further questions in the chat. So with that, I just want to thank you for your time and your expertise. That was a lot of really good information, and it's really relevant to our practice here in North Dakota because we're just on the very beginning of the CHWs. And so I'm excited about it. Those that are on the call, if you have further questions, don't hesitate to reach out to the CAP Center. We want to continue to collaborate with all of our pharmacy partners and maybe on this work in the future. So thanks, Dr. Eisenbeis. Everybody take care and have a great week.
Thank you.
Thank you. Bye.